All right, so the first skull projection we're going to do is for the lateral skull. So I'm going to have my patient come in. Your centering for this exam is 2 inches superior to the eam. Again, your eam is your external acoustic meatus, or the ear hole. I just think eam is funner to say. It's funner or word? Whatever, you guys know me. So approximately going to be here-ish. So I'm just going to align my upright bucky, because touch the tube, touch the bucky. And now the thing about this one that's kind of difficult for students at first is you can't have your patient in true lateral because you're going to have a lot of distance between the cranium and the upright bucky. So there would be magnification, it wouldn't fit on your 10 by 12 lengthwise cassette, which is what you use. So I'm going to have my patient start in more of a PA oblique position. And then I'm going to grab your head a lot now. I'm going to take her head and get it as close as I can. And the big thing to be sure of here is that the patient's head isn't tilting the top of the head towards the IR or the face towards the IR. You want to minimize the rotation and tilt. This is really fun because oftentimes head imaging now usually goes to CT, but when you get skull imaging, it's typically, if it's not a Waters and it's lateral skulls and that kind of thing, it's typically like a 16-year-old boy, that got into a fight, and it's really fun to dead-eye him when you're positioning them because they're really uncomfortable because we know why they're there. So you just grab that head and just make sure that you have them nice and straight. You also want to make sure that the face isn't really going to be flush against the IR. Our heads typically, most of us, kind of come out at a prominence near that zygomatic arch or cheekbone, and then we start to go in again towards the mandible. If we put our face directly against that, we're either going to be leaning one way or the other. So you really just want good and straight. Okay, so I'm going to have her go forward just a smidgen. And perfect, we have light field in front and behind. But I'm going to go down just a little bit because we're clipping the back of this occipital. Perfect. Right there. Realign that bucky. I'm going to scoot this. If you have to shift just a little bit, go ahead and do that. Okay. And again, I'm just going to get her a little bit closer since I had her move while I did that. Tube. Get my marker up in the light field in the corner. The other thing here, we don't care about the mandible. As long as you have the cranium, you're good. The other last thing you want to make sure is that the ear to the inferior orbital margin is aligned. That line needs to be parallel to the bottom of your cassette or perpendicular to the edge of your cassette. Typically, most people in a regular head tilt position, that line's pretty much aligned, but just make sure. I'm just going to take a little tool here so you can kind of see what I'm talking about. And you just want the line from the ear hole to the inferior margin of the orbit to be aligned. So I have that, so I'm happy. Again, make sure that I have light field behind, which I do. Make sure she's not tilted. I'm going to bring her in just a little bit closer again, just to reduce as much magnification as possible. And I would go ahead and expose that lateral cranium projection. So the next projection that we're going to do is the PA skull. The PA skull is going to be where we start doing almost everything the exact same for the rest of the projections for the most part. Only thing that's going to change is tube angles. So for all of these projections, and I'll just say it obviously as I get to each projection, your OML needs to be aligned. And again, your OML, and I'll just steal this little doohickey again. Your OML is the line from your ear hole to the outer campus, so it's right here. So you want that line to be perpendicular to your IR. So when I do position her for this image, I'm going to have her tilt her head down so that that line is perpendicular to the IR. Okay? So I'm going to have you face towards the board for me. This image is going to exit the nasion, so I'm going to bring the this down just a little bit because I have a feeling we're going to have to come down from that lateral. This is now a lengthwise cassette. You were crosswise for your lateral skull, but the rest of these are going to be lengthwise. So I'm going to get my patient in real close, and your forehead and nose are going to touch the IR. That's typically what's going to get that OML aligned. So I'm just going to have her look down a little bit. Perfect. Make sure that OML is aligned. Entering the back of the skull to ensure that it's exiting the nasion. So for this image, I'm going to come down just a little bit on flaw. Make sure my bucky is lined up. And then the only other thing I want to do is make sure that she's not tilted or rotated. Take a side step to your right, please. Perfect. Get right nice and centered. OML is still aligned really well. Make sure you get your marker on there. So I'm putting a right marker on the right side within that light field. 40-inch SID, and then again just 10 by 12 lengthwise, exiting the nasion, so entering the back of the skull to exit the nasion. Forehead and nose typically would be touching the IR to make that OML aligned, and that would be your PA skull. I'm going to have claw stay just like that because the next image that we do is the PA axial skull, the Caldwell method, and everything about this stays the same except your CR angle. So your CR angle is now going to be a 15-degree caudal angle. The next projection we're going to do is the exact opposite of your PA skull. We're going to do the AP skull. So I'm going to have you put your back against the board for me. This one can be really challenging. Typically this would be done recumbent if necessary. In reality, you're not really going to do this projection because if they can tilt their head, you're going to be doing this in a PA, but it's still on the list of things you can test for, so here we go. This one can be challenging because getting the OML aligned and getting the head against the bucky is really challenging because we have the extra tissue from our shoulders and our spine in the back. So I'm going to take my patient's head, I'm going to tilt it down so that the OML is aligned, and then this is uncomfortable, but you're almost going to just kind of push your head back so you feel really squished. Perfect. And then this is entering the nasion. Bring this up just a little bit to the nasion. Again, the nasion's that bridge of the nose. I'm going to move her just a little bit. And then perpendicular beam for this AP skull. Put my marker down. 10 by 12 lengthwise still, and this is your AP skull. Same as your PA, OML perpendicular to the IR, 40-inch SID. I'm going to keep her like that because I'm just going to do go straight to the AP axial. This is the opposite of the Caldwell. Since for the PA axial, the Caldwell method, we do a 15-degree caudal angle, we're now going to do a 15-degree cephalic angle for the AP. Everything we do in PA for the most part in X-ray, the opposite's going to be true in AP. Get that entering the nasion again. Make sure you realign that bucky. Get that light field and your marker in, but otherwise everything else is again the same. OML is aligned perpendicular to the IR, 10 by 12 lengthwise cassettes being used, 15-inch cephalic or 15-degree cephalic angle for this image, entering the nasion. Next projection that we're going to do is the Haas method. Your Haas method is mirrored pretty well with the Townes method, so I think it's sometimes easier for the skull because there's so many projections to try to classify them together for similarities. So your AP and PA obviously would be tied together. Your axials, Caldwell and AP, would be tied together, and then the Haas and the Towns would be tied together, because they essentially show the same things within the skull when done properly. You just have changes with your CR angle, and that's it. So I'm going to, for the Haas method, that is a PA projection, so I'm going to have my patient face towards the board. The OML is still aligned for this, so that is one thing that's consistent through these projections that are either AP or PA, and your axials. All of those should be aligned to the OML. So excellent test question freebie, unless it's a lateral or an SMV, what line needs to be perpendicular to the IR? It's your OML, okay? So I'm gonna have my patient tilt down just a little bit, and this one is a little bit challenging for students. It's a 25-degree cephalic angle, and it's going to enter 1.5 inches inferior to the inion. And the inion is that bony prominence on the back of the skull. A lot of times, if you've had long hair, it's kind of where you put like a lower ponytail, not a super low one, but like just a lower resting ponytail, but you should be able to feel it almost close to where Claw has her hair clips in today, actually. So 1.5 inches below that, it's really kind of the uppermost part of that squishy portion of where the cranium and the skull meet, is where you're going to want to center your CR. Inevitably, this should exit approximately 1.5 inches above the nasion. I've noticed though with patients that that is not always totally accurate, so don't worry too much about that looking perfect. Just worry about your entering point and make sure that you have the full cranium within your light field when you finish. So I'm going to go ahead and center this to the inion, or 1.5 inches inferior to the inion. I'm going to shift just a little bit, get that nice and centered. Perfect. Down. And they're both there. So make sure my tube and bucky are aligned again. Touch the tube, touch the bucky, otherwise you're gonna get a picture of nothing. And you're gonna notice your light field comes off in this kind of, can't think of the word right now, but it's going to project it outward. It's not going to be a full rectangle. Trapezoid, is that the right word?
Yeah.
Trapezoid. And that's okay, that's just what's going to happen because you have the angle on your tube. I'm going to get my left marker that I had for my APs moved over to the correct side so that I don't have to repeat my exposure. Again, 1.5 inches inferior to the inion. OML aligned. I'm going to get her just a little bit closer to the IR because I feel like that's going to just shift a little bit then. And again, always verify when you're doing your images that you're not having tilt or rotation of that cranium. So if you need to come from behind and just feel with your hands that there's no rotation, go ahead and do that. But that would be your PA axial Haas method, 25-degree cephalic CR angle. So the next projection that we're going to do is a AP axial Towns projection. This is the sister image to your Haas. There's a couple of differences with the CR, but beyond that they show basically the same anatomy. I really struggled as a student to differentiate the angulation between the two. So one of them, the Haas method, has a 25-degree cephalic angle, and the other one, Towns method, has a 30-degree caudal angle. The thing that really helped me as a student was when I heard the phrase, you can only go 30 miles per hour downtown. I mean, think about it when you're in the city or in housing areas, you can only go 30 miles an hour. Well, you can only go 30 miles per hour downtown. Down is caudal, so for your Towns method, you do a 30-degree caudal angle. That helped me. As long as I could remember that that was the one that was the 30 caudal, I could remember the other one was 25 degrees cephalic. I have no fun rhyme for that one. But hopefully just knowing and having one for the Towns method helps you for the Haas method. So Townes method, same as the other ones that we've done for the APs and the axials and the PAs. OML is going to be perpendicular to the IR, so I'm going to have my patient shift just a little bit this way, perfect. And we're going to tilt her head down and then get it as close as we can. And then this image enters 2.5 inches above the glabella. So for most people, it's approximately right at your hairline. So we'll go right there. And then just make sure, again, touch the tube, touch the bucky. I'm going to drill that into you kids till the end of time. This would still be a lengthwise cassette. Make sure you have that little bit of light field. OML perpendicular. Get that CR nice and center. Make sure there's no tilt or rotation happening. And then go ahead and get that marker in your open light field. Okay? So 30-degree caudal angle, entering 2.5 inches above the glabella. Again, your glabella is right in between those superciliary arches or your eyebrows. It's right about that hairline. And that is how you perform an AP axial Townes method. If you need to, if you have limited room with your machine, you can have the patient sit for this exam if necessary. So the last projection of the skull we're going to do is the SMV. The most important thing, I don't know if I was even over here when I started talking, so I'm going to restart. Okay. So the last projection of the skull we're going to do is SMV. The first and most important thing I want to reiterate over and over and over again, or will be reiterating over and over again during this, is you need to move quickly for this exam. It is incredibly uncomfortable, and if you are dawdling, this is specifically my students, if you're a stranger that just showed up here, obviously I don't know you, I can't enforce this, but if you're my children and you are testing out and you pull this projection, if you leave the patient back in this position for anything beyond 10 seconds at a time, I'm stopping your exam. This projection makes people that have any sort of blood pressure disorders or any high susceptibility to getting dizzy or fainting. It's really likely that something could happen, so you should have them seated for this exam if it's necessary, or recumbent with their torso up on a sponge so that the head can tilt back far enough. But I will show you how to move through this quickly so that you are able to get the image that you need obtained, but without making your patient pass out. Okay? So your end goal here is you're going to be aligning the IOML, so think back to the lateral skull. This is the only other one where your IOML needs alignment. So your IOML is going to be aligned parallel to this image receptor. So the line from the ear hole, the eam, to the inferior orbital margin needs to be parallel. So what I always do is I hold and kind of give support to my patient. I always use a chair or something where somebody's going to be able to feel like they have support also, by the way. But I put one hand on their back and then I just take their chin and I just have them tilt their head back. I'm going to have you come back up for a second. So I can already tell she's going to be low. So I'm going to move this so that I can already have it ready. Will you go up just a little bit just so your back's not at the back of the chair? So just up just a smidge and then try to, yep. Perfect. So again, making sure that head's parallel, you just need you back just a tiny bit more. Okay, go ahead and go right back up for a second. So in between me adjusting things, I'm going to let her rest her head back upright. Going back and forth too much can also cause some problems with getting dizzy and uncomfortable, but holding back like that is usually just a strain on the body physically anyway. So close your eyes for me if they're not closed. I'm going to realign my bucky because she was actually almost perfect to where she needed to be. So touch the tube, touch the bucky, get that aligned. And again, just putting hand on the back for the support, tilt that chin back. And this centering is going to be 3/4 inch anterior to the eam between the mandibular angles. Go up one more time for me. I just have to move this bucky one more time. So in between the mandibular angles, 3/4 inch anterior to the eam, IOML parallel to the IR, And go ahead and lean back one more time. Making sure that there's no head tilt or rotation, getting right on that SP. Get that marker on. And that is your SMV projection of the skull.